renal cell carcinoma after nephrectomy. Definition: renal cell carcinoma (RCC) is a kidney cancer that originates in the lining of the proximal convoluted tube, a part of a very small tube in the kidney that transports primary urine. RCC is the most common type of kidney cancer in adults, responsible for approximately 90 and 95% of cases.
Sunitinib is a tyrosine kinase inhibitor that targets a number of receptors, including the vascular endothelial growth factor receptors. Currently, anti-angiogenic therapy such as sunitinib is first-line treatment for most patients with advanced renal cell carcinoma. But immune checkpoint inhibitors such as nivolumab and ipilimumab have demonstrated significant efficacy in previously treated advanced renal cell carcinoma, raising the question of whether they can be used as first-line treatment. In the open-label international Phase 3 CheckMate 214 trial, 1,096 adults with treatment-naive advanced renal cell carcinoma were randomized to receive nivolumab plus ipilimumab or sunitinib. The co-primary endpoints were overall survival, progression-free survival, and the independently assessed objective response rate in patients with intermediate or poor risk as determined by the International Metastatic RCC Database Consortium Prognostic Score. Among 847 patients with intermediate or poor risk and a median follow-up of 25.2 months, those randomized to nivolumab plus ipilimumab had significantly improved overall survival, 75% versus 60% for sunitinib at 18 months, and a significantly improved objective response rate, 42% versus 27%. Progression-free survival was not significantly different between the groups because it did not meet the pre-specified threshold for multiplicity testing. Grade 3 or 4 treatment-related adverse events occurred less frequently with nivolumab plus ipilimumab than with sunitinib, 46% versus 63%. But more patients discontinued nivolumab plus ipilimumab due to adverse effects, 22% versus 12%. The authors conclude that in patients with intermediate and poor risk treatment-naive advanced renal cell carcinoma, overall survival and objective response rates were significantly better with nivolumab plus ipilimumab than with sunitinib. Full trial results are available at nejm.org.
Application in medicine. RCC occurring show a male predominance over women, classic triad, hematuria, flank pain, and abdominal mass. Today, RCC is often asymptomatic, meaning few to no symptoms, and is a general detected incidentally when a person is being examined for other ailments. Pros and cons. Pros. Among patients with locoregional clear cell renal cell carcinoma at high risk for tumor recurrences after nephrectomy, the median duration of disease-free survival was significantly longer in the sunitinib group. Cons. Survival was significantly longer in the sunitinib group than in the placebo group at a cause of a higher rate of toxic events.
STRAC is the adjuvant randomized phase 3 study comparing sunitinib with placebo in high-risk individuals with renal cancer who have had nephrectomy and in surveillance and follow-up. It's an adjuvant study. You get a year of sunitinib at 50 milligrams standard doses, and it's against placebo. And the trial shows a significant progression-free survival advantage statistically, with a hazard ratio of 0.76. The central review and the independent review are different from each other. The central review and the clinician's review, they're different in the results. One's significant and one's not significant. But essentially, the hazard ratios are 0.76 and 0.81, which are in the same ballpark as one another. And what that shows us is the results are marginal from statistical significance. One's just one side and one just the other side of significance. And that's really important. And there's no survival advantage in this study. The hazard ratio is 1.0. And that means we're not curing patients. Now, some people say that might be a bit early, but we've got a previous trial with Assure, similar design, which also didn't show, this one didn't show any progression-free survival advantage, and also didn't show a survival advantage. And essentially what this is showing us is that while we're showing signals that may or may not be promising for progression-free survival, we're not seeing anything in overall survival. And patients obviously want overall survival. That's the goal of this. Because in the adjuvant setting, we are going to over-treat a group of patients who don't relapse. And so therefore, what I would like to see before I start recommending adjuvant therapy is I'd like to see either a positive progression-free survival meta-analysis, so we can confidently say you can delay the time of the cancer to come back, number one. Future trials that are positive, or an overall survival signal starting. And one of the issues in the way I look at that is that if we had a small difference, a trend towards a survival signal, that would be promising and would suggest there's a relationship between the two of progression-free and overall survival. But because there's currently no relationship, it suggests to me that all we may be doing is just delaying progression-free survival, but not actually helping patients cure their cancer.
Issue update in Ecuador. In Ecuador, the most common carcinoma in the different subtypes of cancer is renal-cell. Among the most important factors are great rates as or overweight, addition to hereditary predisposition. In conclusion, the renal-cell carcinoma is more common in older men. Risk factors including smoking and obesity. Many cases of renal carcinoma are asymptomatic. When symptoms do appear, they include pain in the side of the body or back, blood in the urine, or a lump in the abdomen. Treatment may include removal of the kidney or the affected part. Treatment options are immunotherapy, targeted molecular therapies, or localized radiation therapy.